Now here is a beginner surgeon. He's trying to manipulate the lens into the bag. The lens doesn't seem to be centering well, and he realizes there's something fishy. And this is the time he calls for help, and this is what I'm seeing now. But interestingly, he hasn't noted anything alarmingly suspicious until now. So as I settle myself under the microscope, I can see that the rhexis is intact, but I can see that the lens is almost dangling deep inside, probably into the antivitreous, and the proximal haptic is just tugging at the rhexis margin. It was very obvious for me that probably the posterior capsule is not intact in time to pull out the lens. The lens is gently maneuvered out of the bag. The proximal haptic is first nudged out, followed by the distal haptic. I'm using triamcinolone acetate to stain the vitreous, and then a bimanual antivitrectomy is being performed. In a couple of minutes, the prolapsed vitreous is taken care of. In the meantime, I noticed that the rhexis margin has ripped off, and probably this has happened during removal of the lens because the rhexis was slightly smaller. So negotiating the slightly bigger optic of the PMMA lens would have ripped the rhexis margin. Once the prolapsed vitreous is taken care of, time to put in the lens. So the space is created with OVD under the iris and above the anticapsule, and the lens is just slid under the iris. So using a PMMA single piece lens to be placed in the sulcus, care is to be taken that the haptics are oriented in such a way that they are 90 degrees away from the tone rhexis. Time to do the analysis, and let us rewind and see where things went wrong and why was it not noticed earlier. So I'm going to fast forward the video clips of the initial steps of the surgery which are not contributing to this complication. The scleral tunnel is done, the rhexis is done, which is quite nice. The nucleus is manipulated out of the bag into the antechamber, and then using a phaco sandwich technique, the nucleus is managed to be extracted out. The epinucleus is burped out. Time to remove the cortex. As the surgery is a manual small incision cataract surgery, the surgeon is using a Simcoe cannula to aspirate the cortex. To begin with, the focusing is not so great. Nevertheless, he is using the side port to ensure that the chamber is maintained deep and nice, so that he can remove the cortex in a very safe way. Once the chamber is maintained deep, it's quite easy and safe to engage the cortex and then strip it over. The cortex in the nasal quadrant is first taken care of. It's gently stripped and it is aspirated nice and easy. Subsequently, a few more quadrants of the cortex are then aspirated out. And now we have the area of the cortex remaining, which is not so much accessible through the side port. The surgeon is now trying to aspirate the cortex going through the main incision. One can note that the surgeon is very circumspect because he's worried about the shallow chamber and the risk of rupturing the posterior capsule. We can see a lot of holes. Chamber is indeed shallowing. Somehow the surgeon just manages to engage the cortex and keep stripping. However, with a lot of focus, he still achieves to remove that a bit of cortex as well. And now the sub-side port incision cortex is remaining, and after that the case is literally done. Now the Simcoe cannula is again introduced to the side port and trying to aspirate the cortex in the 11 o'clock zone. Okay, the surgeon is now going through the main incision and trying to remove that small chunk of cortex which is there under the side port incision. Now this area is very tricky. The moment the cannula is introduced, we can see that the antechamber is shallowing. There are a lot of holes in the cornea and the posterior capsule. But the surgeon is so focused on catching hold of the cortex, he's missed something. Hang on, I think, have you picked this up yet? We can clearly see the posterior capsular tear happening now, which has not been picked up by the surgeon, obviously. A circular defect is very well seen, Well, of course, this is in retrospect. We are having the benefit of a slow motion video and we have the chance. But this subtle sign has been missed by the inexperienced surgeon. So ignoring this small defect which was there, the cannula is again reintroduced into the eye through the side port, trying to aspirate the small chunk of cortex in the 10 to 11 o'clock area. And by the time we hold the cortex and try to move around, the cannula is actually held the posterior capsule and we can see the posterior capsular tear enlarging. So now it's very obvious that there is the momentary cobweb appearance where the entire capsule is held in the port of the Simcoe cannula. But the surgeon is now focused on removing that small cortex. And although he's possibly seeing those folds in the posterior capsule, he thinks he can still get away. No. So we are seeing these spider cobwebs, and at the same time the aspiration of the cortex is being done. And in a flash of a second, the cobweb disappears and the cortex gets aspirated. Now what has happened? If you rewind and see, at this point, the posterior capsular tear has broken. Now, at this point, let me pause and ask you a question. Is the posterior capsular tear broken or not? If it is, then where are the edges? Well, let us try to rewind and answer these questions. So when the cortex is stripped, the momentary cobweb appearance also goes off, and in a split second, everything just disappears. That there's no demarcation, there's no wrinkling of the posterior capsule, nothing is seen here. So actually what has happened is the PC is still intact? No. The posterior capsular tear is broken, but we don't see any demarcation line in this region. Well, the reason is the posterior capsule tear is so big that the edges are way beyond the rhexis margin. So we can see that the posterior capsular tear edge is near this quadrant. Since the tear was so huge, we didn't have any central demarcation area of the posterior capsule, and that was the reason why the surgeon could not diagnose the posterior capsular tear. We can see that the red reflex is quite homogeneous. There is no demarcation line. This is what confuses most novice surgeons. They're not sure whether the PC is intact or not. And at this stage, possibly the anterior is also intact. There's a reason why there's no change in the shape of the rhexis. Or the second option is the anterior could be broken, but the vitreous is quite fluid in nature, so it is not changed the contour of the rhexis. So these are the things which have made this novice surgeon to miss the posterior capsular tear and then venture into putting the lens in. So obviously once the lens started to descend down, there's a time he realized that something is really wrong, and that was the time help was called for. So the take-home message here is obviously maintaining the chamber is the only secret of preventing or breaking the posterior capsule. So whenever the chamber is compromised, you end up damaging the posterior capsule. But the important aspect is, you see the subtle signs which are present momentarily, and you need to train our mind and the eyes to detect these subtle signs at the earliest, like shallowing of the chamber, wrinkling of the posterior capsule, appearing of the star fold signs, and looking out for any of these demarcation lines in the red glow. These are all suggestive of a possible posterior capsular tear. So that was it. Hope you found this helpful. Thank you for watching.